My co-investigators and co-authors, it is my absolute privilege to present to you the primary results of Odyssey HCM trial, which tested the strategy of mavacamten in symptomatic non-obstructive HCM. Okay. Here are the conflicts of interest. So HCM is a complex, heterogeneous, often inherited myocardial disease, which has an estimated prevalence of 1 in 200 to 500. If looked for carefully, 50 to 70% patients have dynamic outflow tract obstruction, which drives a significant proportion of the symptoms. But patients without obstruction, categorized as non-obstructive HCM, could be symptomatic due to a variety of causes, including diastolic dysfunction, microvascular disease, myocardial fibrosis, etc. Currently, there are no treatment options for non-obstructive HCM. So there exists a major unmet need for safe and effective treatments. Mavacamten is a first-in-class cardiac myosin inhibitor now approved in 50 countries based on multiple phase 3 randomized controlled trials which have shown a significant improvement in gradients, quality of life, need for septal reduction therapy, etc. It gets class 1 and 2A indications in this context. Phase 2 studies in non-obstructive HCM have shown a favorable trend in terms of biomarkers, which set the stage for Odyssey HCM, a phase 3 randomized double-blind placebo-controlled trial conducted, as I said, in about 201 sites in 50 countries to test the strategy if mavacamten improves exercise capacity and patient-reported health status in symptomatic adult non-obstructive HCM. These are the primary results. So here are the selected inclusion and exclusion criteria. Everything was adjudicated by the core laboratories. The patients were diagnosed with non-obstructive HCM. Latent LV outflow tract obstruction was carefully excluded in every patient by use of stress echocardiography at baseline. So were phenocopies. And patients had evidence of diastolic dysfunction as well as elevated biomarkers as shown. Everybody had EF more than 60%. The study schemata, after a screening period of about 35 days, patients were randomized to mavacamten versus placebo. And as you can see, the titration scheme was slightly different than obstructive HCM patients. And everything was titrated based on core lab read echocardiography. Every patient was on stable background medical therapy. What were the primary endpoints? Change from baseline to week 48 in peak oxygen consumption by CPET as well as KCCQ clinical summary score. The study was designed to claim success if at least one primary endpoint was significant following multiplicity adjustment with an alpha allocation for KCCQ of 0.01 and 0.04 and 0.01 for peak VO2. Additionally, secondary endpoints including VEP CO2 slope change, biomarker change, symptom improvement were analyzed, and safety endpoints including EF less than 50%, less than 30%, hospitalization for various diseases listed here were measured. Flowchart at 580 patients randomized. This is the largest HCM trial ever conducted. 569 patients completed the primary analysis. So moving to the results, the baseline characteristics, the groups were very well matched. The patients had advanced disease as evidenced by long duration of the diagnosis, number of patients with background atrial fibrillation, as well as reduced oxygen consumption, as well as elevated biomarkers and KCCQ. Of note, no patient, we did not have an upper cap for amount of beta blocker use or background history of atrial fibrillation. So the primary results, the dual primary endpoint in the current trial, in the primary analysis for the change in peak VO2 from baseline to week 48 It did not reach statistical significance with a p-value of 0.06, and KCCQ had a p-value of 0.056. Because of the statistical analysis plan, additional secondary analysis was not performed, but it did show numerical trends in favor of mavacamten. Graphically, panel A shows least square mean difference in mavacamten group of 0.52 mils per kilo per minute, and in the placebo group 0.03, with a difference of 0.47, which was not statistically significant. Similarly, in KCCQ, the least square mean difference in the mavacamten group was 13.1 points, and in the placebo group was 10.4, with a difference of 2.7 points. Additional secondary analysis showed favorable trends, but were not statistically analyzed. Some selected pre-specified group analyses are shown here, which suggested younger patients, less advanced disease, lesser duration of disease, less diastolic dysfunction. These patients trended numerically in favor of mavacamten. Of note, the folks with beta blocker use, they showed numerical favorable trends in the mavacamten group. Safety events, treatment emergent adverse events, 42 patients had a treatment interruption in the mavacamten group, 15 in the placebo group. Drug discontinuation, 15 in the mavacamten and 8 in the placebo group. Congestive heart failure events, we'll talk about it, 19 in mavacamten and 5 in placebo. Of note, atrial tachyarrhythmias were similar in both the groups. So further, deeper dive into the safety. Discontinuation occurred in 42 mavacamten assigned patients and 15 in the placebo assigned patients. Termination in 15 mava and 8 placebo patients. EF less than 50% occurred in 62 patients in mava assigned group and 5 to placebo, less than 37 patients in the mava and none in the placebo group. However, in the placebo-controlled period, we were able to confirm recovery of LVEF to more than 50% following drug interruption in all but 3 patients. 1 patient was lost to follow, and 2 patients did not return past their 48-week for additional echoes. Congestive heart failure, as mentioned, was observed in 19 patients assigned to mavacamten group and 5 to placebo. However, amongst these 19 patients, only 5 patients had heart failure close to an ejection fraction was less than 50%, which was temporary and recovered following drug interruption. Mavacamten dosing was guided by monthly EF measurements using pharmacokinetic modeling, and about half the patients received the highest dose, while less than 10% received the lowest doses. This is different from the obstructive HCM, where it is mostly the lower doses. This titration scheme probably explains why 21% had EF less than 50%. Longer advanced disease of HCM, importantly, serious adverse event of atrial fibrillation was similar between MAVA and placebo, and there was a 10-point improvement in KCCQ in the placebo group, likely due to optimized background therapy in the trial. Primary results reflect 48 weeks of treatment with no long-term data included. I would like to thank the investigators and the site colleagues plus the patients for participating in the trial. To conclude, ladies and gentlemen, mavacamten in Odyssey trial did not result in statistically significant improvement in KCCQ or peak VO2. Ongoing research in biomarkers, imaging, and responder analysis will identify patients that respond favorably to mavacamten in non-obstructive HCM. This paper is now online in New England Journal of Medicine, and I would like to thank the editors for that. Thank you so much.